Okay.
Welcome to AETCM, the Emergency Medicine Channel.
Yeah, please.
A 42-year-old female presented to ER with complaints of fever with chills of 3 days duration and breathlessness of 2 days duration.
Okay.
On our initial 10-second assessment, the patient was conscious, oriented, obeying commands. Coming to airway was patent, no secretions. Coming to breathing, bilateral V's and bilateral creps were present with a respiratory rate of 30 breaths per minute with a saturation of 92% in room air. At this point of time, we keep the patient in propped up position and started on nebulizations. We also start the patient on supplemental oxygen of 6 liters through face mask. Coming to circulation, BP of 130/70 millimeters of mercury, pulse rate of 120 beats per minute. 2 large bore IV cannulas were inserted during this point of time. Coming to disability, GCS of E3, V4, M6, pupils 2.5 bilaterally reacting to light. Exposure, temperature 102 degree Fahrenheit with a GRBS of 425 milligram per deciliter.
Okay.
Injection PCM 1 gram, IV stat was given at this point of time.
Okay.
Coming to adjuncts of primary survey, an ECG was taken showing sinus tachycardia. ABG was taken, actually we got a VBG showing a pH of 7.07, PCO2 of 23, bicarb of 6.4, glucose of 409, lactate of 1.6, potassium of 3.8, serum creatinine of 1.010 with an ion gap of 20. Point of care ultrasound was done at this point of time showing fair LV, no RWMA, no RARV dilatation and no B lines. CBC CRP point of care was taken showing a total count of 25,000, CRP of more than 230, platelet of 240. Coming to ample history, a 42-year-old female, known case of hemochromatosis secondary to diabetes mellitus, presented to ER with complaints of fever with chills of 3 days duration. Fever was high grade, intermittent and decreases on medication. Associated with breathlessness of 2 days duration, which was gradual progressive from an MMRC grade 1 to grade 4. Associated with productive cough and generalized tiredness. No history of any chest pain, PND, orthopnea, edema, dysuria, seizures, abdominal pain, loose stools, hemoptysis.
Okay. So you said the hemochromatosis secondary to diabetes. Diabetes secondary to hemochromatosis. Which one is correct? Diabetes secondary to hemochromatosis. Okay, that is agreeable. I was just thinking, what is this new thing that I have missed or something? Okay. So so that is the total history. So we have a fair idea about an 42-year-old lady who has presented to the ED. We have symptoms as breathlessness, fever with chills and rigor. And the thing is that when a patient is coming to the ED, our concern, as you said, A, B, C, you have stabilized the airway, breathing, circulation, whatever is needed. But she's coming from home, right? So she's coming from home. That is a 42-year-old, but the problem is that she is diabetes and she is having hemochromatosis. So we will put her, that is the risk factors for her. So these are the risk factors: diabetes, hemochromatosis, 42-year-old lady coming to the ER with breathlessness. On examination, you have found out that she is hypoxic, tachypneic, so initiated on oxygen, and there was wheeze. You started her on nebulizations, and there was no evidence of hypotension as such. Yes. But ABG was showing an metabolic acidosis, high anion gap metabolic acidosis. So this is a classical picture of our presentation of whenever you say a patient with diabetic ketoacidosis that is coming to us, the precipitating factor being one of the most common being an infection. So an infection in that, among that infection will be urinary tract infection and pneumonia. So probably we can call it as probably she's coming from the community. So probably a community acute pneumonia because there is no previous history of hospitalization. When was the history of hospitalization?
3 months he's having.
Still 3 months back?
No, sir. 6 months he is having 2 history of hospital admission, and within 3 months she is having 1 history of hospital admission is there.
Okay, what was the last time that she got discharged from the hospital? It is more than like 2 to 3 weeks. So we cannot call it as a hospital acute infection. So she has received it from the community, but from the community the problem is that she will be prone to develop more of an infections, bacterial infections that is not very commonly seen for a general population. So when we look into that factors, a 42-year-old probably diabetes and with pneumonia. That's what you have to think. Diabetes with pneumonia. So probably what we are dealing in my mind will be a Klebsiella pneumonia. That will be my first differential diagnosis. On top of that, she has got an worsening of her diabetic ketoacidosis also. Maybe she has skipped her insulin doses. We don't know what exactly, but maybe from the history we got an history that she is not regularly on insulin. So now this is the challenge for us. Now how will you go about to manage this patient? So we have seen diabetic ketoacidosis, basic ABC you have done. But diabetic ketoacidosis you need to manage. You need to manage the sepsis also. So both the treatment, one thing is common. What? Fluid management is the most common one. Both require fluid management. So diabetic ketoacidosis also you need fluid management, and here also you need fluid management if the patient is in septic shock. So right now she is not in septic shock. So how will you plan the management for this patient? So that's a clear picture we have. Hemochromatosis, leave it alone. We don't have any specific treatment for hemochromatosis as such. So liver disease, challenges in a patient with diabetic ketoacidosis and sepsis. So how will you manage? What are the challenges that we have here? Fluid management.
So initially we have checked the with point of care ultrasound. We have checked the LV is spare LV, and no B lines were present.
Okay.
First we need to go ahead with management of DKA.
Okay.
We have
So management of DKA. What is the first step?
IV fluids.
Fluid management.
We have calculated the corrected sodium. Corrected sodium came at around 128. So we started on NS at a rate of 250 to 500 ml per hour.
So the first 1 hour, how much fluid do you need to give?
1 to 2 liters.
You have to approximately, she's a very young lady, maybe not to that built and all, it's not there. Maybe you are giving a too much of fluid also needed, but maybe around 1 liter of fluid will be sufficient enough. The next 2 hours?
4 liters can be given.
Next 2 hours, 4 liters?
Half of it.
Half of it will be sufficient. The total deficit, what you need to remember in an DK will be around 6 liters. That you need to correct it. So when you are thinking enough of HHS, it will be somewhere around 10 to 12 liters. So that is a basic difference. Can we have an patient, how will you differentiate between a DK and HHS?
DK is most common in type 1 diabetes patients. HS is type 2 diabetes.
Now everywhere we can see, both types we can see
the
DK.
presentation DK will be more acute presentation. HHS, the history will be 3 to 5 days of not taking proper insulin and coming with a altered sensorium like presentation.
Yeah, that is the most important thing. When you look into the altered sensorium will be the key. There will be hyperosmolar, hyperglycemic state. Previously what it called as diabetic coma also. They used to call it as coma. But now it's hyperosmolar, hyperglycemic state. So they can they have acidosis? HHS.
Yes.
HHS can have acidosis.
Usually pH, there is no acidosis like that.
Usually the pH will not go beyond 7.25 and all. Maybe mild acidosis you will be able to say. Bicarbonate will not fall down less than 15. So that is one differences that you can make it out. And the classical blood sugars will be above 500, 300, 500, sorts of range. So that is a basic difference, and only treatment aspect that is the change is the fluid management requiring is a little bit more side. So here there is acidosis, definitely acidosis with hyperglycemia. So our first priority is to treat the fluid. So how much fluid, as you said, 1 liter maybe in the initial hour, then you can slowly, gradually, you can depend upon, in textbook they will say 1 liter, 2 liter, 3 liter, but it all depends upon the patient's additional comorbidities. So same lady, she's having a renal failure also, just imagine. So it is a totally different situation. So every patient you cannot take as the same. So every patient you need to have their own plan. So you need to have non-invasive monitoring like our IVC or simple things like SLRT and all those things. But they need dehydration. But it's not just the intravascular volume as such. It is the extracellular volume also there will be deficiency. So cellular, not just intravascular volume we just need to look into. The cellular dehydration level also we need to correct. So 6 liters you can just take in and you need to give that correction. And what is the next important thing in her?
The correction of the potassium.
So 3.8 potassium, whether you will start correction or you will just wait and see. What will be your idea?
We will start correction. We will maintain a potassium of 4 to 5 actually.
Yeah, there are 2 reasons why we wanted to correct it. One is specifically for DKA. When you are starting on insulin therapy, her blood sugar, her potassium level can drop. So that can further lead on to further arrhythmias. And the next thing is that you need to remember is this lady is already having a chronic liver disease in form of hemochromatosis. So hypokalemia can again precipitate them into the next step, that is hepatic encephalopathy. So we don't want that also to happen. So hypokalemia correction is very important. So if it is like, when will you start? Okay, I need not have any correction. So when you will say, when it is above 5, no need to start any correction. You can just wait and you start insulin correction straight away. But it is somewhere around 3.5 to 4, between 3.5 and 5, we need to add on 20 to 40 milliequivalents into your drip, and should be a continuous correction should be going on. So that is one thing. What is the third step that you need to remember is the insulin correction. Whether you want to give bolus or you don't want to give bolus.
You can, as per our settings, we start on insulin infusion as per Delta protocol. So
okay.
we don't give a bolus insulin.
So where all you can give insulin bolus, or you don't prefer to give insulin bolus? Why you want to give an insulin? Is it required or not? Because some guidelines still say that you can start off in a insulin bolus, especially in pediatric DKAs. You can give an insulin bolus and you can start on an insulin infusion also. Okay, so when the potassium is on the higher side, maybe you can give bolus. See, what is our concern in diabetic ketosis? Our concern in diabetic ketosis is with the dehydration. Sugars, we are not bothered. Sugars, we are not at all concerned at most at this point of time. But I am concerned about hypoglycemias rather than hyperglycemia. Hyperglycemia, we can give insulin and we can correct it. For the initial hour, our concern is dehydration correction. So that is a major thing, and you don't want a rapid decline of blood sugar also. And specifically in this patient, there is gluconeogenesis is not going to happen because of the liver failure. So we are very much concerned here, and so we definitely don't want to start an IV bolus, and we want to give an IV infusion as such, and see the blood sugar and go ahead with the continuous. So what are the targets that you want to achieve by blood sugar?
We need to maintain every hourly 50 to 70 milligram per deciliter reduction is needed, and we will keep the target around 150 to 200, and if less than 200 come, we will start on DNS.
Okay, there are some guidelines say 250, some guidelines say 200. So it's all about, you don't want a rapid decline of blood sugar. So that's it. You don't want a rapid decline of blood sugar. So if that happens, you would change into either 5% dextrose. You stop your normal saline and you change to 5% dextrose, and continue your potassium correction if it is required as such. So that is regarding your DKA management. And the overall, you want to convert after maybe 24 to 48 hours, the acidosis is settling, the ketonemia is settling, everything. You can think of switching over to, when you switch over to the normal 3 times or 4 times boluses. When will you switch over?
Once the acidosis get corrected, the serum ketones become negative, the patient starts to take oral feeds.
That's more, the last one is more important for me. When the patient start taking orally, you can easily move on to boluses. But here, even if there is no DKA, I'll be preferring her to continue for a little bit longer time on an insulin infusion till the sepsis gets resolved. So that is also one important thing, not just diabetic ketosis, she is also having an additional sepsis also. Now we'll come to the sepsis part. So sepsis management here, we are thinking in terms of a bilateral pneumonia. That's what we are most probably. Now the question is whether it's viral or bacterial. So I'll be concerned here will be when we can use procalcitonin, and we can just see what is a procalcitonin. 58. So definitely it's a bacterial infection because of her comorbidities. She is coming from even from the community. We have to think in, but there is frequent history of hospital admissions also. So what is the antibiotic that you want to start? Don't say what we have started. What is the antibiotic that you want to start in her?
We need to cover both gram positive, gram negative and MRSA coverage. So to be...
Okay, so gram negative and gram positive, I'll agree. So as I told, Klebsiella is one thing that I'll be concerned here. MRSA as such, maybe at the initial point of time will not be concerned unless and until you are getting an X-ray which is showing a pneumococele and she was hospitalized and there is a high chance of developing an MRSA. Maybe in that situation we will think of, but routinely yes, we will be thinking in terms of a probable Klebsiella sort of a pneumonia. But the same patient who's been lying in the hospital for 10 days, you are treating with carbapenems, then you are seeing some pneumococele forms in the X-ray, then definitely you have to think in terms of probably an MRSA. So that is MRSA coverage. Maybe initially the treatment aspects will be what agent, what you want to give here. So how will you decide a patient which antibiotic is needed for any patient that is coming to emergency room? Any patient that is coming to emergency, just think about pneumonias.
We stratify the patient as high risk and low risk.
Okay, most importantly, where they are coming from. That's the first question that I need to answer. Where they are coming from home, or they are coming from hospital, how long in the hospital they have been settling, what all antibiotic they have received if they are coming from the hospital. From house also they will have received already some antibiotic and they will be coming to us. The next, as you said, the risk stratification. What are the underlying diseases that have, whether they have malignancy, whether they have any diabetes, whether they are only any drugs that can decrease the count. These are the next thing. So that is the risk factor. So patient selection, from where they are coming, age group specific risk factors, and specific risk factors for them as in terms of comorbidities or any drugs that they are taking. Suppose the most stable one that is coming from the community. So what all organism you will suspect?
We need to cover gram-positive.
Most common is viral. Remember that the most common ones are viral pneumonias. So most common there only is viral pneumonias. So they are coming to the hospital. Maybe they can start off with no need of antivirals for all patients, unless pregnancy or any of the extremes of age, only you need antivirals as such. But otherwise they doesn't need anything. Maybe a symptomatic management will be more than enough. So that is one group. So as you said, this next group, what are the things that you will suspect? Gram positive, the common one, the Streptococcus, H. influenzae, and all those things are the common organism that we will suspect. Staph aureus as such, MRSA won't be there, but maybe to some extent staph infections also. And you have got a lot of other group of organism which is called as atypical organism. Your chlamydia, legionella, and mycoplasma and all those things. So the classical history that you will get, an IT employee who is coming, who is there in the sitting in the AC for a long time, and he is coming with an atypical sort of a pneumonia. So what is atypical pneumonia? They don't have the classical pneumonia like symptoms. Instead of they have fever, loose stools, they have generalized weakness, maybe hyponatremia, altered sensorium and all. They will not have any respiratory issues as such. So but when you are dealing with, that will be probably an atypical pneumonia. So atypical pneumonia, what history on the IT employee, what you will suspect?
The air conditioner.
So for what? Legionella you need to suspect. So our agent selection will be depending upon these factors also. So we have a dictum to start azithromycin for all patients. So azithromycin covers what? It has got very good gram positive. It has got atypical coverage also. So it don't have a gram negative and an anaerobic coverage. So that is azithromycin. So we want to just treat any of these agents. So azithromycin will be more than enough. What are the other options? We want to treat as an OPD basis in the emergency room. Fluoroquinolones, we have to be very specific. I will add an adjective to also, respiratory fluoroquinolones. So there are certain group of drugs which is respiratory fluoroquinolones like levofloxacin and moxifloxacin. These are the commonly, sparfloxacin and all was there, but the most commonly used one is levofloxacin. So levofloxacin, again, when you think, it has got very good gram positive coverage, it has got atypical coverage, it also has gram negative coverage, and it also has got anti-tuberculous coverage also. So this is the last one, is little bit concerning for me. Just like that, we might not start for all patients. Maybe like 3-day short history and all you can give. But if you're thinking like 1 week, 2 weeks, 3 weeks and all, it has got anti-tuberculous effect also. So suppose you are giving levofloxacin, it can mask the patient and patient can come back without resolution of complete pneumonia. So maybe azithromycin initially will be very good agent. The next agent, what will the other agent you can give is doxycycline. Doxycycline again has got very good gram positive, atypical, all this coverage is there, and again it doesn't have any anti-tubercular effect also. So these are the 3 agents that we can commonly recommend for any patient when they are stable and coming from the community. Now we'll come to this patient, okay. Some come to this patient, she's coming from community, yes, but she has got risk factors. So when you are having a patient like this, as I told, Klebsiella is my concern. What are the other, what is the antibiotic that you wanted to choose in her? You wanted to give a very good broad spectrum antibiotic which has got good gram negative coverage. Very good gram negative coverage, that should be enough. Maybe a ceftriaxone initially or ceftriaxone sulbactam initially when you are suspecting, but with the comorbidities and maybe she's having frequent hospital admissions, maybe we can think of starting on an piperacillin tazobactam. Also, we can start upon an respiratory levofloxacin. Yes, you can start, but I'll be concerned maybe because of the seizure threshold might come down due to levofloxacin, and she's more prone to develop hepatic encephalopathy at any point of time. So levofloxacin maybe will bring it a little bit on the lower side. But if she is in septic shock, she is presenting with septic shock, but she has already gone into one of the complication, maybe straight away you can start with carbapenem, then you can de-escalate her on antibiotic. So why we started on meropenem? The answer being, she is already having hemochromatosis, multiple hospital admission, so stance of multi-drug resistant will be very common. And the next important thing is that she already have developed one of the major complications of an infection, that is diabetic ketoacidosis. So any gram-negative infection can produce this, but we started her on carbipenem because of all these factors, and later you can de-escalate her maybe after 48 hours or 72 hours if the culture turns to be negative, or if you don't see anything in the major in the culture, or you are getting a culture specific antibiotic, you can bring it down. So that is the reason why we have selected. Maybe linezolid, after seeing the x-ray, we thought there are some pneumatocysts formation and all. That is the reason why we started her on linezolid also. So every patient, the treatment is not the same. So these are the tick boxes that you need to tick in when you want to start which antibiotic you wanted to start. That is the decisions that you need to make. So first you have select the antibiotic. What are the other things that you want to do? Any sepsis patient, there is hypotension, you have to give fluid, measuring the serum lactate level. So serum lactate level, obviously it is going to be high for this patient. The reason being there is underlying liver failure. So the lactate clearance is going to take a longer time. Then the next important thing is blood culture, taking a blood culture. And if there is hypotension, further hypotension, you need to start her on noradrenaline. So that is the drug of choice. So challenges, one being DKA treatment and fluid management, we already started. Diabetes control, yes, we need to do the diabetes control also, plus antibiotic of choice. So what was done for her? Can you elaborate?
So we initially started, as per this complication, we started the patient on carbapenem.
Okay.
And coming to the updates in diabetes, diabetes mellitus refer to a group of disorders that shared a common phenotype, that is hyperglycemia. Initially, we noticed that there are three key players, that is liver, muscle and pancreas, that were contributing to this hyperglycemia. Now we have identified 5 more factors, that is called the ominous octet of DeFronso. Then we come to the dirty dozen, treacherous 13, faithless 14, and at this point of time, we have identified 16 factors that contribute to this hyperglycemia, that is called the sweetening system. Coming to the classification of diabetes, earlier we classified diabetes as type 1, type 2, type 1.5, that is KPD-LADA, type 3 diabetes, where type 3C, where the disease of the exocrine pancreas, that is hemochromatosis, comes, and type 4, that is gestational diabetes. Coming to the latest classification, we classify diabetes as SAD, that is severe autoimmune diabetes, SID, that is severe insulin deficient diabetes, SIRD, that is severe insulin resistant diabetes, MORD, that is mild obesity related diabetes, and MARD, that is mild age related diabetes. SAD and SID are basically type 1 diabetes, and SIRD is type 2 diabetes, and MARD is type 4 diabetes. Thank you.